All right, so immunization competency for school nurses. So not everyone can know everything about immunizations, including myself. I was an immunization coordinator at VCU for almost 9 years. And before and after, spent most of my life giving immunizations to both school-aged kids and younger kids and beyond. Next slide, please. So some general information. So first of all, this course is sort of the down and dirty of giving immunizations and what we expect of our MRC volunteers to come in and be able to do. So volunteer vaccinators have to, at a minimum, receive training on the infectious disease targeted by the vaccine, contraindications and precautions. So contraindications are the absolute cannot receive this vaccine. Precautions are things that you should take into consideration and figuring out if this is the right time to give the vaccine. A review of the administration route and technique. Again, there's no buts in immunization, so we never want to use the gluteal muscle for any immunization. And we'll be talking a little bit about correct site. There's a few choices that you can make about sites, but they're very limited. Also, a review of emergency procedures, including responding to anaphylaxis and vasovagal events. Vaccines are very safe. Anaphylaxis is truly rare. In my entire 35-year career, it's only happened once. And that was at a flu clinic from somebody who had received influenza administration for almost 45 years in the Navy and post-military service, but had also started a different medication the same day. So we're not sure it was from immunizations, but it was, you've always got to be prepared. And then also some OSHA considerations for vaccine. Next slide, please.
I call Felicia and tell, do you have her number?
So for vaccination clinics for VDH, we do expect that a fully trained public health nurse must be on site at the time of the clinic. That person's going to serve as your resource in the clinic and your go-to person if you have any questions. We also expect all staff to follow current PPE guidance and safety measures for the event. And we're going to be going over a little bit about what appropriate PPE is in this time of the COVID pandemic. COVID has really put a monkey wrench in our pods or points of dispensing, and it's beginning, we're really working through some of those glitches there. Remember that we always use 2 patient identifiers, first name, last name, and date of birth. You do have to make sure you have the right patient before vaccinating. Individuals who are vaccinated must wait 15 minutes post-vaccination before leaving the area. Those of you that have been doing drive-through clinics know that we kind of missed that the first time around when we did our planning, but then had to build that in and make sure there was some way that a parent could pull the car up and wait for 15 minutes. If you're going to have syncope, it's usually within those first 15 minutes after vaccination, same if you're going to have an issue. We do not pre-draw or pre-mix vaccinations. This may change with the COVID-19 vaccination because it's going to have some complex mixing involved and also thawing and bringing to appropriate temperatures before injecting. And always know the contraindications and precautions for the specific vaccine. Next slide, please. OSHA considerations. Become familiar with the sharps that will be used during the event prior to the event. If you have not had a few minutes to practice using the sharps, whatever is going to be supplied for the event, ask for time. We've had 2 recent needle sticks with volunteers who were using sharps that they were not familiar with and assumed they knew how to close the device. Typically, we order BD Eclipse and we order Safety Glide and we order Vanish Point. We have ordered less Vanish Point because we did have some issues with Vanish Point because you have to actually push through the vaccination and the needle retracts. And some people didn't push hard enough or some people pushed hard enough to make it retract before you even deliver the dose. So my message is know those safety devices and don't be afraid to ask for someone to show you to make sure you know how to use it. Know who your safety officer is and the importance of reporting bloodborne pathogen exposures, and review disposals of hazardous and non-hazardous waste. So with some of our COVID vaccines and COVID testing events, some of our newer products, the entire kit is considered biohazard waste. So make sure you know what goes into the biohazard container and what does not. Again, look for slip, trip, and fall hazards and report all safety issues to the event safety officer or public health lead. Next slide, please. So vaccination during the COVID-19 pandemic. Boy, hasn't this been fun. So we're going to require at least physical distancing of at least 6 feet between family groups. And if a family is in one group, we are asking to be, cognizant of even if only one person is being vaccinated, not to separate the family group. We do not want children left in cars or outside our health departments or outside the pod unattended. Every individual who's being vaccinated this flu season or during this vaccine season has to be screened for symptoms of COVID-19. For those or exposure to COVID-19. For those with confirmed or suspected COVID-19 or direct exposure, delay vaccination by 14 days after last known exposure for those exposed and 10 days after symptom onset for those who have known COVID or suspected COVID and 24 hours with no fever reducing medicines before vaccinating. Next slide. So gloves should be worn when administering nasal or oral vaccines, but they are optional and always have been for administering injectable vaccines. If you wear gloves, they have to be changed and hand hygiene has to be performed between each client. VDH and our infection preventionists do not allow you to keep the same pair of gloves on and clean the pair of gloves with hand sanitizer. That is not an acceptable infection control technique, nor is double gloving, removing one set of gloves and moving to the next patient. If you do not wear gloves, you need to perform hand hygiene between each patient. Right now, we are currently recommending a surgical or procedural mask. We prefer that you use those instead of a cloth face covering because cloth face coverings are not considered PPE. And we're asking, and we have found that it is helpful to wear a face shield while you're vaccinating in areas where transmission is ongoing. I think we can pretty much say most of Virginia transmission is ongoing. So if you're not issued a face shield and surgical mask, you need to ask to be issued one. Those do not have to be changed in between each client unless somehow they're soiled. N95 respirators are not recommended at all. Individuals who are being vaccinated should either wear a surgical mask or a cloth face covering. So that's for the individual, not for the vaccinator. Next, please. Other general considerations, know who the team leads are for your vaccination event. When in doubt, you have any questions, ask a seasoned public health nurse or your safety officer. And be prepared for syncope. I hate having to vaccinate people in pods standing up. I'm anticipating most of our pods will be drive-through, so at least they'll be sitting in their cars because the main events that I get and event reports are from people who faint and smash their faces after they are vaccinated. And you guys are really good with that because you're used to that in your populations as well. Again, anaphylaxis is rare. Next, please. So the first vaccine we're going to cover is influenza vaccines. We'll go to the next slide. So what are symptoms of influenza? And what I'm also trying to cover, hint, hint, is what is on the test that you have to take. So I'm sure this slide deck will be sent out, but some really key points are going to be in red. But most of us know the symptoms of influenza, which also mimic the symptoms of COVID-19. So you can have co-infection with influenza and SARS-CoV. And we are thinking that the outcome is much more serious in individuals who are co-infected. Initially in this pandemic, we didn't think you could be co-infected. So if we tested you positive for flu, we didn't test for COVID. So we're encouraging the entire country who is eligible to get a flu shot this flu season. So far, we've had no shortages. There haven't been any massive lines that I've seen, but that is the recommendation. Next, please. So IV, I love the way we call it LAVE, IV, TIV. So IV is inactivated influenza vaccine. That's the one we're all most familiar with. That's the flu shot. It's the one that we can give to almost everybody, and it is the formulation that we typically will issue when doing our drive-through flu clinics or any of our influenza pods, points of dispensing. Contraindications are rare. It's really a history of severe allergic reaction after receiving a previous dose, or if they have an allergic reaction to an influenza vaccine component. And then there are some precautions that some people will say are absolute contraindications, but not true. And then again, they have currently an illness. Again, because this is COVID, even though that hasn't been removed from the precautions, if they have symptoms of COVID, we're not going to vaccinate. History of Guillain-Barre is just a precaution. It is not a contraindication. This is the formula, again, that we typically use in our clinics. We typically ask our MRC to vaccinate older children or adults, not young children. It's not contraindicated for immunocompromised individuals for the most part. There's always those 1 or 2 outliers, but people who are HIV infected with low T cell counts can receive this vaccine, ding, ding, test question, and should receive only 1 dose. We often are asked if people can receive a half dose and come back 4 weeks later because somehow they're convinced they have reactions to it, or if they can get a second flu shot in the season just to give them the boost. And that's not recommended, and that's not what we do at VDH. Next slide, please. So let's see. I don't know. Yep, let's go to the next slide. Again, we usually have our mass vaccination clinics in October. There was no recommendation this year to really give a big push to early influenza vaccination clinics. Influenza viruses usually start to drift and change at the end of the season. So we like to get the dose in October so that we're ready for our peak season, which is usually January, but can be as late as March. There is live attenuated influenza vaccines. So I think the key here is that live attenuated, the attenuated is the key. It's not really quote unquote live vaccine. It's been sort of modified so that it's not infectious. And that's Flu Mist, only one company makes it. It's gone off and on the list of vaccines that are approved each flu season, mostly because there have been a lot of concerns that it hasn't been as effective in preventing disease. This vaccine is for ages 2 through 49. There is a laundry list of contraindications to this vaccine. Again, this slide will go out to you and take a look at these contraindications, but know that this is the reason why we typically want to give IV in our drive-through and our pod situations, because more people can use it. This vaccine cannot be given to immunocompromised individuals. It cannot be given to pregnant women. It cannot be given to people with any immunocompromising conditions like CSF leaks. For children from 2 to 4 who have been diagnosed with asthma. So there's a lot of contraindications and precautions to this vaccine. Next slide, please. So these are some of the precautions. I think one of the biggest ones to think about, since we usually use this vaccine in children, is the contraindication in asthma in children aged less than or equal to 5 years old. Again, all of these chronic conditions, think of it as this is the only vaccine that you can use on ages 2 through 49, folks that are healthy and well. Next slide, please. So children ages 6 months through 8 years of age who are receiving influenza vaccine for the first time should receive 2 doses at least 28 days apart. It's sort of like priming the system. We're not sure if that's also going to be the case when COVID vaccine is available for children. We do know that COVID vaccine is a 2-dose series for most adults. The interesting thing is those 2 doses don't have to be the same formulation for influenza vaccine. It gets really confusing if the child is in that age range, had one flu shot for the first time last flu season. Now this is the second flu season, and we're trying to remember, figure out, does he need one dose this season, or is this the second dose, or does he need another priming dose? I would really encourage you to go to your PHNs in that situation and seek guidance.
What happened to
Denise, if you could, Denise Quickendall, I believe that is, if you could stop sharing, that would be awesome. Because I believe it kicked out. Let's see, Joanna, go
Yeah.
ahead and share your screen
Yeah,
again.
I'm trying to kick her out. So give me just a second.
Okay, great.
It says we'll stop other screen sharing. Do you want to continue? Yes. So hopefully that.
So
Okay.
while we're waiting for that to come back up again, let me just share that we are still preparing for the COVID vaccine. I was granted access to the site for Pfizer just today. I've got to log in. That will give me some feeling for what the contraindications and precautions will be for the COVID vaccine. So more news to come on that. Next slide, please. Thank goodness for Joanna. Otherwise, I'd be lost forever. So egg allergy and vaccination. For years, we have said that an egg allergy is a contraindication to vaccination, and it is not. And there are more formulations that are not egg-based in their preparation. So there are algorithms for those that are truly egg allergic, and that is a very small portion of the population that anaphylaxis to eggs. We do have DNA recombinant flu vaccines now that the health department does not typically carry, because those have to be, they're much more expensive and we don't have enough of a demand for them. However, even though it's not an absolute contraindication, we typically don't vaccinate egg allergic individuals in our mass clinics. We ask for those folks to go to their private physician's office, or we refer them to somewhere where we know they can be watched a little more carefully. So again, if they're truly egg allergic, we don't vaccinate. When in doubt, ask your public health nurse. Next, please. So again, RIV is the recombinant influenza vaccine. It's not licensed for children less than 18, but it is one of the ones that is not 100% egg-free, but getting there. And Flucelvax. So you see RIV4 and CCIV4 is licensed for those greater than 4 years. And again, this is another alternative to egg-based manufacturing processes. It's a cell-based vaccine. It's very safe. But again, we don't typically stock either one of these two in the health department because the demand is so low. But you probably will see these in your regular pharmacists. We've been able to refer people to chain pharmacies who are truly egg allergic, and they've been able to receive this vaccine. Next slide, please. Administration and route. So there are no home brews or butts in vaccination. And what I mean is you never mix two vaccines in any syringe or any adjuvant unless it is specifically for that vaccine. And we never give vaccines in the gluteal region. They are not well absorbed, and most will have to be repeated if they're given there. So really, for most of the vaccines that I'm talking about today, I am in the deltoid or the vastus lateralis in the leg. We really typically only use the vastus lateralis for very young children who just don't have the muscle mass in their deltoid. I really don't anticipate our MRC volunteers being asked to vaccinate children who are that young. Again, please don't deviate from the injection sites or from the injection route. If you have any questions about needle size, really we typically use for most children and adults a 1-inch needle. We really like to stick to a 23 to 25 gauge, pick the smallest you can. Although you can give a flu vaccine with a 22 gauge needle, that's sort of like using a fire hose when a sprinkler system would do. So we typically order basically either 23 or 25. Janine orders 25 because she really doesn't want a big needle in her arm for most of our clinics. And we usually have mostly 1-inch needles on site. Occasionally I will have someone who is so obese that I have to use a 1.5 to feel like I'm going to make it into the deltoid. Or those big football players and basketball players that have like these ginormous muscles, I'll use a 1.5 to make sure that it gets in there. Next slide, please. So common adverse events for flu vaccine are redness and at the injection site a sore arm. It does not cause the flu. Anything you can do to dispel that myth will be greatly appreciated by all of public health. Next slide, please. Tdap or tetanus, diphtheria, and acellular pertussis. Next slide. So these are the disease targets. Tetanus is the one I would highlight to you that is not infectious person to person. Let me say that again for the test, not infectious from person to person. It's a spore that lives in the ground and still exists today. Once you complete your tetanus series, you don't have lifelong immunity, which is why we say that you need those boosters for dirty wounds. I've seen actually a couple of actual cases of tetanus in my life. One when I worked in the neuro ICU, and it was an individual who had been gardening and was into natural medicine, and from what we could tell had never received initial tetanus vaccine. Diphtheria is a gram-positive bacillus. It is communicable from person to person. We have very few diphtheria cases in the United States. We really have very few tetanus cases in the United States anymore. But the disease that we have the most cases is pertussis or whooping cough. And pertussis is communicable person to person. You do not have lifelong immunity. You cannot do a pertussis titer and think that you are immune for pertussis because the antibody levels are very flexible. So pertussis, remember, is the one that is communicable person to person and has the most cases in the US. Tetanus is not. Next slide, please. And I believe Tracy is sending out this PowerPoint. Again, pertussis has accounted for most of the disease burden targeted by this vaccine. Complications can be very severe in young infants and children, but less severe in adults. Next slide, please. This talks a little bit about the primary series. For most of us who have been in the field for a long time, we remember when we had DTP, and that was a whole cell pertussis vaccine. And that's where you really saw some of the neurological poor reactions or bad reactions in the early 80s, perhaps up in even to the early 90s. Now we have acellular pertussis vaccines, which have removed a lot of the side effects. So this is your typical primary series that you see. And often what we're asking you guys to help us with is that booster dose at 11 or 12 years or before 7th grade of Tdap. Next slide. So adults that are unvaccinated or that we don't have a record for, and these are 3 doses. They really recommend, preferably the first, that it's Tdap and then 2 doses of TD to follow. Tetanus toxoid that some of you may be familiar with, people used to call it the horse serum tetanus, like I had a reaction to the horse serum tetanus, tetanus toxoid, is no longer available for purchase in the United States. So you'll never see that kind of vaccine again. Next slide. So again, this slide talks about wound management. There is a question on the test about wound management. And really, it's basically, if you have had your primary series and you're more than 5 years past when you had your last booster and you had a massively dirty wound, we would give you a booster. Tetanus immune globulin is something that we only give IV, and it's only to individuals who never had a primary series of vaccine. So I think it's a busy slide, but it kind of gives you the idea. If I've had my tetanus, I need to be up to date. If I have a dirty wound that's massive, small wounds we're not quite as worried about. We can go out to 10 years. There is a syndrome that you can get with tetanus that causes an arthus type reaction, a severe reaction in the shoulder. And then we really recommend waiting 10 years between boosters. Next slide, please. So contraindications, again, severe allergic reaction after a previous dose of a vaccine component, and encephalopathy, and that means coma, decreased consciousness, prolonged seizures, not that you have another cause within 7 days of a previous dose of DTP, DTaP, or Tdap. We used to say if you had a high fever after Tdap that was a contraindication, but that's not any longer. Next slide, please. So again, precautions, again, GBS, less than 6 weeks from a previous dose, uncontrolled seizures until your treatment regime is stabilized. And again, that history of that arthus type hypersensitivity reaction, most people who had that had tetanus toxoid, which is no longer that capital TT, which is no longer on the market, but you can defer vaccination for at least 10 years. And again, particularly in this time of COVID, if you have COVID symptoms, please don't vaccinate, because it's going to be hard for us to tell you whether it was a reaction to vaccine if you have something happen, or if you are, it was something that was COVID related. Next slide. So again, we give it IM in the deltoid or vastus lateralis. Deltoid is preferred. A 1 to 1.5 inch needle. 1 is really sufficient. Let's not use a garden hose when a nice gentle immunization will do, and do not administer in any other site. So if you have to give 2 vaccines, say you're giving HPV and Tdap, the preferable way of doing it is to separate them in 2 different anatomical sites. So 1 in one deltoid, 1 in the other. But say you're giving Tdap, HPV, and meningococcal IM, then we say you have to separate them at least by 1 inch if you're going to give 2 in the same arm. What I like to do is give the 2 that hurt the least first, which is typically Tdap and meningococcal. We have more complaints for HPV, so I always give the HPV last. For some reason, people say that stings more, so I try to give the least painful one last. As far as aspiration, most of us were taught in nursing school to aspirate before we injected if we're giving any IM vaccine. The CDC says there's no reason to do that if you are in the deltoid. It's not going to hit anything. You're still going to aspirate those antibiotics or whatever you're going to give anywhere in the ventrogluteal or gluteal. You want to create as little pain as possible. So you're going to inject slowly and steadily, just get it in there. If you are in the right place, you're not going to hit a vein. So that is actually in the pink book, and that is a CDC recommendation that VDH endorses. Next slide, please. So really, we haven't found any unexpected safety concerns for the general population, including pregnant women and for adults over age 65. Remember when we had our pertussis reducing campaigns, we did start vaccinating older individuals, and for pregnant women, vaccination is now recommended with every pregnancy. They have found no association between Tdap vaccination and Guillain-Barre or other neurological disorders. That was a huge concern when Tdap was first released. Again, injection site reactions are common, but they're really local reactions, redness, and they're really, they're very short-lived for Tdap. This seems to be a very well tolerated vaccine. Next slide, please. Okay, Tracy, Joanna, I'll get you to take it away.
Thank you so much, Janine. So I'm going to take over for the HPV vaccination. So I'm going to try to do two things at once, run the slide and talk at the same time. So many of you are aware that the HPV infections are associated with other cancers, not just cervical cancer. And most infections are without any symptoms. And as far as cervical cancer screening, we're well versed in that. Screening is done by a pap smear. And keep in mind that there is no specific treatment for HPV infection, and that may be a test question, just to kind of head you guys up on that. HPV vaccine can be given to boys, not just girls. It offers long-lasting protection against the HPV infection for both and disease, but most important thing we need to remember is, and that's kind of why some of the guidance has changed on this HPV vaccine recently, is if a child finishes the HPV vaccines by age 13, they have the most protection. And keep in mind that both males and females ages 11 or 12 years old is our target population. And if we think about the guidance that we received from House Bill 1090, which will be our July 2021, will take effect. HPV added boys changed from 3 doses to now 2 doses, changed from 6th grade to 7th grade. Families still have the option to opt out of it, but I would strongly encourage you guys to educate your families about it. It's, when you tell people that there is a vaccine to prevent cancer, that may be a turning point for them. So kind of make sure that you help out with any vaccine hesitancy that you may be having from your families, as far as educate them on the benefits of HPV. We've got some great literature on the immunization site for the Virginia Department of Health, some great infographics, great brochures. So feel free to take anything you need off of those. As far as when we start talking about vaccines, if they start before their 15th birthday, it'll be 2 doses. The first dose, and then the second dose will be around 6 to 12 months later after the first. If they start after age 15, then it'll be 3 doses. And of course, it'll be the first day, and then the second dose will be 1 to 2 months after. And then the last dose, which will be that third dose, will be 6 months after the first. So that's 3 doses are only if it starts after age 15. If it starts before the 15th birthday, it'll be 2 doses. And keep in mind, guys, that the this document that goes with immunizations, it's required by law to make sure that you provide that information and document it. So when you're working in your clinics, make sure that you have copies available for parents. And when we start talking about storage and handling, a couple key points here is you want to make sure that the vaccine is stored between 2 and 8 degrees Celsius. You want to make sure that you protect it from the light, and vaccines should be shaken well before administered. Keep in mind that any immunization clinic that you guys decide to set up in your schools or in your community, please reach out to your local health department. One, for the vaccines, but also to help you with the storage. That's probably one of the most critical aspects of all of this, is proper storage and handling. So please make sure that you reach out, partner with, and understand. Okay, and when we talk about contraindications and precautions, really big one you guys want to make sure is that any allergic reactions, You want to make sure that you're fully prepared for any type of anaphylactic reactions. You want to make sure that if they're allergic to yeast, that you do not give the HPV vaccine. It's not recommended for use during pregnancy, and vaccine can be administered if someone has a mild illness, but if they have a severe or moderate illness, you do not want to give the vaccine. You want to wait and defer it for a time when they're not having any type of illness. And that's very important. As far as administering of the HPV, you want to, just like Janine said, you want to follow the same recommendations that she had. You do not have to wear gloves, but if you do wear gloves, you want to make sure that you put on a new pair before the next person, and make sure that you do hand hygiene, perform hand hygiene between folks. If you're not wearing gloves, you want to make sure that you wash your hands or use hand sanitizer. You want to do hand hygiene between. The HPV vaccine is a half a milliliter. You want to, of course, make sure, as you do with any vaccine, that you check for expiration dates. You make sure that you look at the vial itself and make sure that the vials had no damage and that the contents look clear, that there's no real cloudiness or particles in it or something that would prevent you from using it. And as far as the vaccine itself, you're going to administer it the IM route, preferably the deltoid 90-degree angle. And as Janine said, make sure that everyone is, all the students or children are seated, because you could run the risk of them getting a little fainty on you. And like she said, we don't want any smashed heads or faces. We want to keep them the way they were when they got there. Make sure that once you do administer, that you observe them for 15 minutes for any adverse reactions. And the adverse reactions that you want to look out for is swelling or redness at the site, temperature of 100 or greater. Of course, any anaphylactic reactions, keep in mind of those, and watch for syncope or fainting. Of course, as Janine had said before, HPV, she recommends that we give it last because it does sting a bit more than other vaccines. Make sure that you use that 1 to 1.5 inch needle, and I mean 1.5 inch needle, and then 25 gauge needle, just to, smaller needle, so that it's not quite as painful. The one thing she said that would be helpful is don't aspirate, just inject it slowly and steadily. You're not going to hurt anything if you're in the deltoid in the right place. And that's kind of the HPV in a nutshell. There is a references, the CDC has a site called You Call the Shots, and you're more than welcome to go back and look over that. It has information on Tdap, it has information on HPV, and has information on the flu. When COVID comes out, I'm sure there'll be more information on COVID that you're welcome to use or look at. Tracy will, of course, send out these slides like she always does, and we will also have the recording for you guys to listen to. As far as going forward with our vaccinator training, we've spoken with the MRC folks, and all of you who have registered for the class and the course, you will receive an email from Tanisha Short, and she will have the exact steps to do next as far as your train account, to be able to go back in, set up the train account, and be able to take the post test that you need to take. I will encourage you to not try to do anything at all until with your train account until Tanisha Short emails you, because she's in the process of setting them up now. And so that may take just a little bit of time. In the meantime, if you are looking for something to do, the MRC site for school nurses that has been set up has a link that you guys can go to, and you can register and submit your MRC volunteer application. You can go ahead and fill out the necessary information, and Tanisha will be sending that out also in her email to let you guys know exactly how to fill that out. But if you want to get a little jump start, you're more than welcome to fill that out. I have posted that information on our Padlet back to school website. If you look at it, it has a section for MRC volunteers. It has the instructions on how you can go about setting up your MRC application. And once Tanisha sends out the email, we'll go ahead and post that additional information. But to follow up the course that we've done today with Janine and the one that was on Tuesday with Jennifer Freeland, the next steps will be to set up the MRC volunteer account, followed by setting up your train account and then taking the post test, and then there'll be an evaluation. Once everything is completed, the train system itself will offer certificates of completion and offer contact hours for those who have completed both courses and taken the test and filled out the evaluation. So going forward, we're really looking forward to working with you guys as far as MRC volunteers. We're really excited to have the capabilities of being in the school and helping out our school population. The one thing that I will encourage all of you to do is, if you did by chance miss that first course by Jennifer Freeland, like I said, we'll have that posted. You're more than welcome to go back. If you decide after today that you want to be an MRC volunteer and you missed that first course, you're more than welcome, if you want to email me or Tanisha, and you're more than welcome to view that first course and catch up with everyone else. So we're very grateful. We're looking forward to being able to catch kids up who have missed their vaccinations due to COVID. Like I said, early in the year, we were experiencing about a 23% decline in vaccination rates. And we're extremely encouraged by the participation of the school nurses, being MRC volunteers, being able to get your school community up into compliance. We're also excited that you guys are willing to, host flu clinics to help out your communities and potentially be able to help out with a COVID vaccine. Without you guys, we couldn't do it. So feel free to spread the word, ask any questions. And like I said, those of you who have not registered for the first class or were not considering being an MRC volunteer, but you are now, please do not hesitate to let us know, and we can help you get where you need to be. So I want to thank you all for your attention, and I'm going to send it back to Tracy.
Hey, Tracy, before she sends it back to you, I'm going to jump in for a minute. I have a few things to share about COVID vaccine if we have just a few minutes. Is that okay?
Yeah, we do. That's fine.
Okay, so this is going to be the biggest vaccine campaign in history. I don't think, and that's any secret. Let me see, COVID vaccine plan. Can you see my screen or no?
Now I see you. Joanna, can you unshare yourself?
I have. It's just probably taken a minute
Okay,
or two.
sure. There
Can you
there
see
it
my
goes.
screen now?
There it goes.
So I just wanted to share a couple of things about what we know so far about the COVID vaccine, because we're going to need everybody's help to get this vaccine out there, and that includes you guys. So we're trying to be extremely transparent in what we know and what steps we're taking to be safe. I don't think I have to tell you the case for the vaccine. We definitely need it. But I wanted to share some of what I know about the vaccine candidates here. So we have several coming down the pike. I know most of you saw that Pfizer released that they feel that their vaccine is almost 90% effective. That's pretty good, but remember that's after 2 doses. So we're going to be splitting into waves. We expect possibly to have the Pfizer vaccine first and possibly Moderna. So those are the two that we're looking at. Both are ultra cold storage for us. So one is at -70 degrees Celsius, which is unbelievable, and the other is at -40 degrees Celsius. So people have asked a lot of questions about how are we making sure this is safe. The one thing that we keep hearing is that we've moved too fast. So I just wanted to sort of throw this up here and let you see what the safety profile has looked like. The FDA, the ACIP have really put the brakes on going quote unquote too fast. Remember that there were some vaccines in development for SARS and MERS long before we ever had COVID. So we're not starting from scratch. The other thing that we have now is decades of vaccine experience and the science to go with it. So do know that these trials are ongoing. We will be continuing to monitor all of these vaccines for adverse safety events, and we're doing everything we can to be as transparent with the public for when we notice an issue that we address it immediately. So something that you can all help us with are thinking about the equity considerations for COVID-19 vaccination. We know we're facing mistrust and skepticism. People are concerned about the cost. It will be free of cost. They're concerned about equitable distribution of resources and how we're going to distribute this vaccine. So we have formed the Virginia Vaccine Advisory Work Group. This is with folks inside and outside the agency. All of these meetings are transparent. They're posted on Town Hall. You can sit in on any of them that you would like to. We do them all by WebEx, so they're very safe. We have co-chairs. I'm on the Vaccine Safety and Efficacy group that is really looking at how we're going to monitor this in Virginia. We have portal-based reporting systems for issues with vaccine, anything that we feel has gone wrong. So we're trying to do everything we can to get as real-time data and real-time information to you as we can. These are all the people that are on the Vaccine Advisory Membership Work Group. I mean, you can see that we have all kinds of pharmacies, hospitals, health insurance companies, organizations, healthcare coalitions, institutes of higher learning, religious groups as well, just to make sure that we're taking all issues into consideration and really working on breaking down those barriers to vaccination. So here's what we're thinking is going to happen during phase one. Phase one is going to be a very limited vaccine supply. So we're really looking at only being able to vaccinate healthcare providers during that time. And we may have just enough to vaccinate some healthcare providers. Phase 1B is going to be essential workers and people at high risk of COVID-19. Again, we're targeting the nursing facilities, working on a way to distribute those doses. Phase 2, and we don't really have a set timeline when all this is going to occur. That's when we're really going to be pushing out vaccine into communities and looking at critical populations and populations at higher risk. So that's where we're going to really get our MRC volunteers involved, our retail pharmacy, mobile clinics, those of you who lived through the nightmare of H1N1 vaccination in the schools, get ready, here it comes again. And we're going to really be relying on you guys to help us get that vaccine out there. So again, we have a plan, we have a workbook. We're working with multiple providers and how we're going to get this drop ship to sites, how we're going to manage the inventory, manage the input. You guys are our partners on all of this. Again, these are the phases that we expected. These are the risk categories. As you notice, young adults and children are really not until phase 3 of this campaign. So when you're thinking about people asking, when is school going to get back to normal? Well, we're probably not going to be vaccinating children really until phase 3. So we're looking at a little ways down the road. It depends on how fast the supply chain can make the vaccine. And if we don't have any hiccups, will we stop giving a vaccine because we see an issue? So again, these are the priority groups. possible priority groups. We still don't have it nailed down by the CDC, but this is what we're using for planning assumptions. Again, phase 1A is healthcare personnel. We'll probably start with healthcare personnel in high-risk situations, which are hospitals, nursing facilities, again, essential workers. We're still trying to define what an essential worker is. Those with high-risk medical conditions, we're still trying to define what those are. Adults over 65, we pretty much figured out by birth dates who those groups are. But again, how that rolls out, we're still working on. So these are all the things that we currently don't know. It feels like we have more unknowns than knowns. We have lots of people enrolled, and I'm just going to kind of go through these slides, and I'll stop sharing now. I just wanted to give you a flavor of what is the avalanche and tidal wave coming, and that I really see school nurses as being part of that effort, and they're going to be key to getting school kids and school staff immunized. Public health is not going to be able to do the lift alone. This is going to be massive. It's going to make H1N1 look like a walk in the park. So in preparation, I cut off all my hair, got a haircut yesterday, so I'm ready.